In the last video, we talked about the repercussions of men's health being the standard on which the health of women is based. And it's important to realize that all those things can also apply to culture and ethnicity. In this video, we're going to talk about culture and health, so it'll be useful to start out by defining culture. Culture is the criteria that we use to delineate social groups. It can be based on skin color, ethnic background, language, customs and traditions, and social class. A more technical definition of culture is that culture is a set of ideas, behaviors, attitudes, and traditions that exist within large groups of people, usually of a common religion, family, or something similar. Cultures vary widely around the world. One cultural difference is the amount of space people like to put between themselves and others. The physical distance people place between themselves and others in America is larger than the distance people put between themselves and others in parts of Europe. In many places in Europe, people often stand closer together when speaking, and even tables in restaurants are closer together in Europe than they are in the United States. Okay, so why do social and health scientists care about culture? Well, the primary reason is that there are pronounced and persistent group differences in mental health and physical health that are based on culture. Group-based differences in health are called health disparities. In the last video, we talked about health disparities based on gender. There are also health disparities based on sexual orientation, disability, and geography, but today we're going to focus on disparities based on race and ethnicity, culture, education, and income. Before we move on, let's define ethnicity and race. One definition of ethnicity proposes that an ethnic group consists of 6 main features. 1. A common proper name. 2. A myth of common ancestry that gives an ethnicity a sense of fictive kinship. 3. Shared historical memories, which include heroes, events, and their commemoration. 4. One or more elements of common culture, which need not be specified, but normally include religion, customs, and language. 5. A link with a homeland. And 6. A sense of solidarity on the part of at least some sections of the ethnicity's population. Race can be defined in a variety of ways. One way is that race can be defined as a local geographic or global human population distinguished as a more or less distinct group by genetically transmitted physical characteristics. 2. Race can be defined as a group of people united or classified together on the basis of common history, nationality, or geographic distribution. Or 3. Race can be defined as a genealogical line or a lineage. Just to give 2 examples of health disparities based on ethnicity and race up front, one group of researchers has found that blacks and ethnic Hawaiians are more likely than whites to get lung cancer if they smoke. That's what these graphs are showing. Data from men are on the top, and data for women are on the bottom. African Americans are the blue line, and Native Hawaiians are the purple line. As you can see, in each graph, these 2 groups have a higher risk of developing lung cancer than white people, Japanese Americans, and Latinos. It's not exactly clear why this is. It's possible this difference results from different biological or genetic predispositions to getting lung cancer, but it's also possible this difference is due to some unmeasured environmental difference, although this study did control for diet, income, and occupation. Another group of researchers has found that melanoma, or skin cancer, is less common in blacks and Hispanics than in whites. And that's what these graphs are showing you. The dark bars are blacks, the gray bars are Hispanics, and the white bars are whites. Clearly, whites are diagnosed with melanoma much more often than blacks or Hispanics. But if blacks or Hispanics get melanoma, it's much more likely to be diagnosed at an advanced stage compared to when it's diagnosed in whites. This suggests that doctors are probably not checking blacks and Hispanics for melanoma as often as they should, possibly because this disease is so rare in these groups. Differences in health based on culture have been noticed for as long as people have noticed culture, or race, or status within a culture. One early physician who pioneered the public health movement of the 18th century in Europe pointed out that there is in every state a necessary social order among the citizens. The inequality in the distribution of wealth determines the different social classes. Since every social class must have its own diseases determined by the different mode of living, we must expect that under any form of government, the rich and the poor will have diseases peculiar to them. The opposite of health disparity is health equity, which means that everyone has a fair opportunity to attain their full health potential, and nobody should be disadvantaged from achieving this potential. That is, people of equal needs should have equal access to care, equal utilization of care, and equal quality of care. While various physicians through the years concerned themselves with the issue of health disparities based on cultural factors, it wasn't until the 1960s that a significant interest in this topic came about, and it wasn't until 1985 that the government generated a formal report on health disparities. That report was the Heckler Report on Black and Minority Health. The major finding from this report was that 60,000 excess deaths, that is, dying in excess of the average death rate, occurred each year in our country because of health disparities, primarily among African Americans. At that time, African Americans were our largest minority group, which is why the report focused on them. The report had very little impact at the time because there was weak commitment from the government. This was during the Reagan era, and the public wasn't focused on issues of civil rights at the time. But the report did lay the groundwork for future awareness, documentation, and efforts to understand and eliminate health disparities. The person who really brought this issue into the forefront was David Satcher, the Surgeon General under President Clinton. Under his leadership, the National Institutes of Health adopted a definition of health disparities in 1999. This definition said that health disparities were differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. Around the same time, Congress passed the Minority Health and Health Disparities Research and Education Act. This act established a national research center on the topic of health disparities and created a strategic plan to address the continuing poor health states of minorities, those with low income, and people living in rural areas. In addition, the two primary goals of the National Institutes of Health, which are rewritten every 10 years or so, and which are currently called Healthy People 2020, are 1, to increase quality and quantity of healthy life for all people in the U.S., and 2, to eliminate health disparities. So these issues are really in the forefront of our nation's public health efforts now. And this has really been seen with the Affordable Care Act, which Obama signed into law in March of 2010. The purpose of the Affordable Care Act was to improve health care for all Americans, and especially for those who were being underserved by the healthcare system. I'm not going to go into any more detail about this act because we could spend an entire semester talking about health insurance in America. I just wanted to point this out because it's the most recent thing our government has tried to do to reduce health disparities. So now we'll switch gears a bit and talk about how various groups differ in terms of health. Let's start with groups based on income, or SES. SES stands for socioeconomic status. It's an indicator of wealth, occupational prestige, and education. People have noticed the relationship between SES and health for a long time, specifically that lower SES is related to worse health. In the early 1900s, in Glasgow, Scotland, people found that there is a relationship between individuals' gravestones and their mortality. Individuals with larger gravestones tended to live longer, the idea being that people who were wealthy could afford larger markers. One researcher in 1924 counted the number of deaths among taxpayers, so the rich, and non-taxpayers, or the poor, and found that for the time span he was looking at, there was a lower death rate among taxpayers, so 10.8 out of 1,000, than non-taxpayers, 24.8 per every 1,000. This study was correlational, so this doesn't mean that you should start paying taxes if you want to live longer, although you should start paying taxes if you aren't already, if you want to live longer outside of jail. Here's another way of looking at this. In this example, two psychologists compared how long Oscar winners lived compared to actors in the same film but who weren't nominated for an Oscar. They found that Oscar winners lived on average 4 years longer than non-winning actors. And people who won multiple times lived 6.5 years longer than non-winning actors who made the same number of films. How do these researchers explain this? Well, they argue that the higher your status in society, the longer you live. This has been shown to be true for very low status people compared to very high status people, which we'll talk about in a moment. But the amazing thing is, these are all actors, and these actors are high status whether or not they won an Oscar. It's just the people who won Oscars have a bit higher status. So admittedly, these are all sort of crude ways at looking at the link between SES and health. But however you look, the relationship between SES and health is almost always found. Basically, low SES is related to high morbidity and mortality, and high SES is related to low morbidity and mortality. In a more rigorous study, Michael Marmot has been tracking 28,000 British men and women and measuring their health in a variety of different ways for the last 40 years or so. His research is called the Whitehall Study. The thing that's so cool about this study is that it's a very uniform group of subjects, because every subject is a British civil servant, a worker in the British government. They all have the same access to healthcare, and they don't have to worry about getting laid off. The British civil service is a hierarchical structure with a precise classification system for ranking all employees in order of the status and importance of their job. So at the bottom of the hierarchy, the lowest SES, are the messengers, porters, and security guards. Just above them are the clerical officers, followed by staff scientists and other professionals. And this last group implements the policies dictated by the most powerful administrators who run the governmental agencies. So this study allows us to look at how differences in status among people who are neither very rich nor very poor affect people's health. In the first set of results from the Whitehall study, Marmot and his colleagues looked at men between the ages of 40 and 64. The differences are quite dramatic. Between the ages of 40 and 64, workers at the bottom of the hierarchy had a mortality rate 4 times higher than that of people at the top. Even after accounting for genetic risks and behaviors like smoking and binge drinking, civil servants at the bottom of the pecking order still had nearly double the mortality rate of those at the top. Fully 2/3 of an individual's risk of stroke was attributable to the person's socioeconomic status. In fact, getting promoted from the lowest level in the British civil service reduced the probability of heart disease by up to 13 percentage points. This graph shows mortality due to cardiovascular disease among the subjects. The y-axis is probability of death, and the x-axis is the number of years during the follow-up. As you can see, the highest risk of death from heart disease was among the workers with the lowest SES, and the lowest risk of mortality was among the workers with the highest SES, the people with the most power. And they've done follow-ups on these men as they've continued to research SES and health within the British Civil Service. These graphs are showing you follow-ups up to 20 years after the original study. What these show is that whether it's total mortality, top left, heart disease, middle left, lung cancer, bottom left, other cancers, top right, chronic bronchitis, middle right, or other respiratory diseases, bottom right, those in the lowest level of the British Civil Service, the black bars, had the worst health. This is just one study showing these SES and health relationships, but the relationship is found in nearly every illness studied by the NIH and in all cultures that have been looked at. The one exception to this rule is breast cancer, which is more common in white women than black women, though black women are more likely to die from it, perhaps because it's diagnosed in black women later in its course. Here's SES and mortality. The x-axis is socioeconomic status, and the y-axis is a standard mortality ratio, annual death rate, and infant mortality, depending upon which line you're looking at. As you can see, individuals with lower SES, the right side of this graph, have an increased standard mortality ratio, an increased annual death rate, and an increased infant mortality rate. Here's SES and morbidity. Again, the x-axis is SES, with the higher SES being on the left side of the graph and the lower SES being on the right side of the graph. And the y-axis is rates of arthritis, chronic disease, hypertension, and cervical cancer, again depending upon the line that you're looking at. Again, you see that your risk increases for these diseases as your SES drops. One researcher remarked that if this was a gene, it would be front page news. So, why does SES relate to health? First, this relationship is not due to low SES people not having access to care. The relationship still shows up even in societies that have universal health care, like among the British civil servants. In addition, the relationship still exists among people in very high SES groups. In fact, this relationship is commonly referred to as a gradient, because for every level of increased wealth, there's an increase in health. The health benefits of more wealth just don't level off. People who make $1 million a year live longer than people who make $500,000 a year. This tells us that the relationship between SES and health isn't solely an effect of poverty. If it was, we would expect it to level off once people had enough money to get the health care they need and to live in safer environments, but it never does level off. The SES health relationship is also not due to people in poor health drifting down the SES ladder. This is the reverse causality argument. People who get sick start to make less money, so their SES decreases. However, the relationship still shows up when SES is measured based only on how many years of school a person had, and that doesn't change as a person gets sicker. This table shows that the less school a person had, the more likely they are to get sick. It isn't that being sick makes you have less education, because the sickness happens long after the education has been completed. And that's easy to see from this graph. Higher education leads to a longer lifespan. What's particularly striking about this graph is the number of years gained for African Americans, both men and women, who complete at least 1 year of college, compared to those who only completed 8th grade. So what does explain this relationship? Well, nobody knows for sure, but consider Nancy Adler's model of how SES might affect health. She argues that SES influences two aspects of the environment. First, physical aspects of the environment, such as how much you're exposed to toxins, pathogens, and noise, and the likelihood that you have a job that'll expose you to risks. So, for example, toxic waste sites are much more likely to be located in or near poor neighborhoods. Second, SES influences social aspects of your environment, such as how much you're exposed to crime, conflict, and crowding, your access to healthy foods, and your access to quality health care. She says that these features of your environment shape your psychological responses. So living in risky environments leads you to have reduced feelings, control over your life, and lower levels of optimism, both of which can lead to worse health. Furthermore, these environmental features also lead you to behave in unhealthy ways, such as smoking, not exercising, eating unhealthy diets, and not adhering to prescribed medications. These things lead to a biological response that she calls allostatic load, which is an accumulation of wear and tear on all your organ systems in response to repeated efforts to cope with stress. Allostatic load increases as SES decreases and is predictive of physical and cognitive decline as well as mortality. Researchers have also looked at cortisol levels in SES. Remember, cortisol is the hormone we release when we're stressed out. When researchers compared cortisol levels and cortisol changes over the course of the day between people of different SES groups and ethnicities, they found that lower SES was associated with higher levels of cortisol. And remember, higher cortisol levels are bad. This becomes very apparent later on in the day. Those making more than $100,000 a year have the lowest levels of cortisol by the end of the day, followed by those who make between $50,000 and $100,000, and those with the highest cortisol level at the end of the day make less than $50,000 a year. Now let's move on to racial groups. Race was once thought to be a biological construct. The races were thought to differ from each other in biological and genetic ways. But, in fact, science hasn't borne this out over time. There appear to be more biological and genetic differences within any particular racial group than there are between different groups. Race is now thought of as a social construction of groups based on observable phenotypic characteristics, so based on features that we can see, such as eye shape, nose width, skin color, and hair texture. Given that race isn't biologically based, but rather socially constructed, how do we measure race? Well, that's actually kind of difficult, but it's thought in the medical community that self-reported race is probably the best way to operationalize race. How other people see us does matter and affect us, but what matters more in terms of health is how we see ourselves. So the best way to measure race is to have people simply self-report their race, or self-identify their race. Our government, specifically the Office of Management and Business, actually provides official guidelines for characterizing race in the United States for official documents and things like the census. They recognize 5 specific racial categories, plus a blanket other category. The 5 categories are American Indian or Alaskan Native, Asian, Black or African American, Native Hawaiian or other Pacific Islander, and white. It's often difficult for people to select a category. That's pointless. Like a completely pointless sentence. Now let's move on to racial groups. Race was once thought to be a biological construct. The races were thought to differ from each other in biological and genetic ways. But in fact, science hasn't borne this out over time. There appear to be more biological and genetic differences within any particular racial group than there are between different groups. Race is now thought of as a social construction of groups based on observable phenotypic characteristics, so based on features that we can see, such as eye shape, nose width, skin color, and hair texture. Given that race isn't biologically based, but rather socially constructed, how do we go about measuring it? Well, this can actually be quite difficult, but it's thought in the medical community that self-reported race is probably the best way to operationalize race. How other people see us does matter and affect us, but what matters more in terms of health is how we see ourselves. So the best way to measure this is to have people self-report their race or self-identify their race. Our government, specifically the Office of Management and Business, actually provides official guidelines for characterizing race in the United States for official documents and for things like the census. They recognize 5 specific racial categories plus a blanket other category. The 5 categories are American Indian or Alaskan Native, Asian, Black or African American, Native Hawaiian or other Pacific Islander, and white. So that's race. Now here's where things start to get confusing. That same governmental office, the OMB, that provides the official race categories that I just mentioned, also provides categories for defining one's ethnic group. According to the OMB, there are only 2 official ethnic groups: Latino Hispanic and non-Latino Hispanic white. This seems crude in measuring ethnicity to only have 2 choices, but it allows Latinos to identify their ethnicity and their race. So if a Latino self-identifies their ethnicity as Latino, then they can also specify a race. So you can be a Black Latino, a Latino Asian, and so forth. Ethnic identity is slightly different. It's your level of identification with a particular ethnic or racial group as defined by you. So one specific person might define herself as Asian or American or Asian American or American Asian or Chinese American or Chinese. The label gives us a sense of those groups the person identifies with most strongly. It's very hard to tease apart race and ethnicity, and they're often used interchangeably, both in science and in day-to-day life. Many scholars and activists prefer the term ethnicity rather than race because it seems to embody culture to a greater extent than the physical features that tend to distinguish races. Okay, so now that we've made an attempt to define race and ethnicity, we're ready to talk about the current trends in racial and ethnic health disparities. This slide attempts to summarize the overarching findings. Most of the research compares Caucasians and African Americans. Usually, the largest differences found are the differences found between these 2 groups. In sum, the groups that tend to be least healthy on most indicators are African Americans, Native Americans, some Latino subgroups, and some Pacific Islander subgroups. Regarding the Latino subgroups, it's been pointed out that particular subgroups that show the most health problems are Dominicans and Puerto Ricans. This is thought to be the case because these are the Latino groups with the darkest skin, and American society generally doesn't distinguish them from African Americans. So if racism leads to health problems, we would expect these groups to be similar in health to African Americans. The healthiest groups on most indicators are some Asian subgroups, Caucasians, and some Latino subgroups. This slide provides a few specific health differences when you compare African Americans with whites. African Americans are 29% more likely to have cardiovascular disease, 40% more likely to have a stroke, and twice as likely to have diabetes. In the first half of 2001, African Americans represented 66% of all new adult-reported HIV cases and 82% of all new pediatric reported HIV cases. Finally, African American males have a life expectancy of 72.1 years compared to 76.6 years for white males. If we look at infant mortality rates, we see ethnic and racial differences too. Infant mortality rates are the rate at which babies younger than 1 year old die. This is considered the strictest indicator of the health and well-being of a society. It's been used to compare the health and well-being of populations both across and within countries. According to the CIA World Factbook, in 2010, the U.S. ranked 34th worldwide on infant mortality, with 5.4 deaths for every 1,000 births. Singapore was ranked first with only 1.92 infant deaths per thousand. Interestingly, the infant mortality rate for African American infants is much higher than the nation's average, at around 14 infant deaths per 1,000 live births, putting this group on par with Romania and Grenada. This graph shows infant mortality among the 5 racial groups identified by the OMB in the U.S., plus the U.S. as a whole. The y-axis is showing you the number of infant deaths per 1,000 live births, and the x-axis is showing you the year. African Americans are that top light blue line. Again, you see that infant mortality is worse among African Americans than any of the other racial groups. There are 3 main problems that come up when you generalize about the health of different ethnic or racial groups. First, SES tends to be confounded with race and ethnicity, and, as we just talked about, SES is related strongly to health, so perhaps ethnic and racial health disparities are due simply to differences in SES. Second, the racial and ethnic categories are themselves actually quite broad and heterogeneous. So you have very different groups lumped together under the same category. So Latino includes both Dominicans and Mexicans, 2 groups that are actually quite different from each other. Similarly, Asian includes Chinese, Japanese, Korean, Vietnamese, groups that vary greatly from each other, but are all lumped together under Asian as if they have a ton of things in common. The third factor that complicates generalizing about racial and ethnic groups is that they may differ in their degree of exposure to and identification with mainstream American culture. And for most groups, health actually worsens as exposure to and identification with mainstream American culture increases. With these factors in mind, we can ask the question, why do African Americans have poorer health than Caucasians? One of the primary reasons is that they're disproportionately represented in vulnerable populations. So, for example, they're more likely to be homeless, incarcerated, in the welfare system, or victims of violence. And they're also more likely to be poor, less likely to be insured, less likely to seek medical treatment, and tend to be underrepresented in health research. On that last point, I might add that we talked in the last video about the repercussions of not being represented in research. In particular, we don't know what a normal health profile is for a particular group if they've been left out of most of the research, and this makes diagnosis and treatments of diseases difficult. For example, African American babies tend to have a lower birth weight when they're first born compared to Caucasian babies. But African American babies are more likely to survive at lower weights than Caucasian babies of the same weight. So lower weights may just be normal for African American babies, and the information we have based on Caucasian babies might not apply to them. Another repercussion of not being represented in the research is that the medications or medical treatments may not work as well. Remember how we talked about antidepressants not working as well in women. Without proper research, we'll remain unsure about whether or not various ethnic minorities respond to drugs in the same ways as whites. Now let me say a few things about acculturation. Acculturation is the process of cultural exchange resulting from intercultural contact. So the longer you're in America, the more acculturated to American culture you're going to be. It's often measured by how many years you've lived in the U.S. or by your proficiency in the English language. It can also be measured by the number of cultural changes or adoptions you undertake. The process of acculturation is stressful, even for people who are the second or third generation of their family to be in the new culture. Acculturative stress refers to the psychological and social demands of negotiating multiple cultural identities. Interestingly, acculturation is linked to worse health behaviors and outcomes. So the longer you live in the U.S., the worse your health. More acculturation to the U.S. leads to more smoking, higher alcohol consumption, more substance abuse, hypertension, obesity, higher rates of HIV and AIDS, lower birth weight, and less use of cancer screening. So this is considered sort of a paradox among epidemiologists. Newer immigrants tend to have fewer resources, including money, but better health outcomes. Just to add another wrinkle to this topic, the country you live in can also influence your health. An article in JAMA from 2006 carefully compared non-Hispanic white people in America to non-Hispanic white people in England. They chose to compare only non-Hispanic white people because they didn't want their results to be based on health issues that appear in the Black and Latino populations in America. They wanted to see if there were differences based solely on what country a white person lived in. So they took medical records from about 10,000 people in the U.S. and about 10,000 people in England and compared them quite carefully on numerous diseases and health indicators using both self-reported outcomes and doctor-measured outcomes. And they found a pretty startling difference. The Americans were less healthy than the British people in terms of diabetes, hypertension, heart disease, stroke, lung disease, and cancer. They found that this difference between these two countries was very strong. For example, diabetes was twice as prevalent in the American sample as the British one. These differences still existed after they controlled for smoking, being overweight, obesity, and alcohol use. So, for example, the difference in diabetes and heart disease is not because Americans are fatter. The researchers point out that these differences are also not due to self-reporting bias, as these differences show up whether they used the self-reported outcomes or the doctor-measured outcomes. The authors also point out that they find strong relationships between SES and health within each sample, although the SES and health link is steeper in the U.S., and that the differences between the U.S. and England are not due to SES differences between the countries. They point out that the differences between the U.S. and England are more pronounced for the lower SES groups in each country, possibly an issue of access to medical care, which every Brit has, but only Americans over 65 at the time had. But the differences still exist for the higher SES people in both countries, which they don't know how to explain. The health of the Americans was so much worse than the British people that the highest SES Americans had worse health than the lower SES British people. These results are rather shocking, in that the United States spends much more per person on health care compared to Britain. So about $5,274 per person compared to $2,164. They suggest that this money expenditure doesn't lead to better health. So what accounts for the differences? Well, it may be that American health insurance may cover your care, but it may not get you very good care. Perhaps Britain's health insurance provides better care. It also may be that Americans work too hard and are just too stressed. Americans work an average of 46 weeks per year, whereas Brits only work on average about 41 weeks per year. It might also be that our social safety net just isn't very good. In England, they take better care of people who are unemployed than we do, and they have more programs set up to take care of people who lose their income because of illness. People there are isolated from the economic consequences of poor health in terms of medical expenses, earnings, and wealth reductions. So they're less in danger of becoming homeless if they lose their job or income due to an illness.